You're the volleyball? Oh, wait, you want to, you guys
No,
want
case
to
one. Go first. Okay.
Case one. 16-year-old female, left hand dominant volleyball player sustained a left shoulder injury while spiking the ball during a tournament. The group should be up here already. She continued to play despite her 5 out of 10 pain and claims that she noticed a decrease in striking power. After the tournament, she went for x-rays which were negative for shoulder dislocation and bony pathology. She now comes to PT 3 days after injury with an empty script for slap tear.
Slap tear.
You are asked to treat this patient for safe return to volleyball activities. Okay, so my thing it might be a little antiquated, so if I skip anything on mine, then you just tell me we missed something, okay? Got it? Okay, so first, guys, I'll ask the questions, you guys will answer in order. This is your whole group? This is your whole group. Good. All right, first, how will the patient, they'll come to the office and complain of what? Pain where? Go in order.
Overhead movement. My left shoulder.
All over the shoulder.
So okay. So they will have what kind of shoulder pain? Diffuse shoulder pain, exacerbated by what?
Overhead movement.
Overhead movements. They also will hear or feel what?
Popping, clicking.
Popping or clicking. Very good. All right. Diana, you ready for the next one? The manual muscle test will reveal weakness in what?
Infraspinatus.
Yes. Infraspinatus, which does what motion? Yes. So they'll have weak infraspinatus, which is external. Don't talk to me.
Yes.
External rotation. Good. What else is weak?
Serratus anterior.
Okay, let's go in order. First you said infraspinatus. Any other sit muscles are specifically weak?
Teres medius.
All the sit muscles are weak. But specifically the infraspinatus, which does external rotation, and the supraspinatus was abduction. So those are, you're not part of this team?
No.
You're just really interested. All right, so all the sit muscles are weak, specifically the external rotators and the abduction. Good. What else is weak?
Core.
Core musculature is weak. Very good. You mentioned something about the scapula. On the scapula itself, what is weak? Matt? Just kidding. Ryan. That was the first time I said it on purpose. Ryan, what else is weak? What else is weak?
Infraspinatus.
No, we said infraspinatus,
Oh, yeah.
we said the sit muscles, we said weak core musculature. What else is weak? The serratus anterior and rhomboids.
Yeah.
And that will present with what? When you watch their scapular, when you take their shirt off and you look at their scapula, what will it look like?
Medial board wing.
Yes, scapular dyskinesia, right? The scapula is not moving properly. Any questions thus far? We know what's weak. We're good? Good. Range of motion testing. Sue-Lin?
They decrease internal rotation and horizontal AD.
All right, so so what is that called, the internal rotation?
It's the posterior muscle.
It's called something. It sounds like you have acid reflux. It's called what? GERD. Glenohumeral internal rotation deficit. Yes, so you're 100% right. Okay. What else? So internal rotation has a range of motion deficit. GERD. What else? You said it. You just said it. I just cut you off. What else, Sue-Lin? What else is weak? What else is deficit? Horizontal adduction. So my question to you: what is the common theme here? What area of the shoulder is tight? If internal rotation is limited and horizontal adduction is limited, what part of the? Yes, excellent, excellent. You have a tight posterior capsule. Because of this constant overhead movement, you have a shift of the humerus, which creates this tightness in the posterior capsule. Good. So posterior capsule / posterior shoulder is very tight. That's what you will find in range of motion testing. Now you test the joint itself. How do you test the joint, Joey? In general, how do you test the joint capsule? What do?
Joint move.
You do a joint move, that is correct. You do a joint move to assess the joint capsule. Okay? So what joint moves are specific for this patient? You mentioned one, you guys, who win.
Anterior.
So
AP anterior.
No, so that might be confusing. AP means an anterior to posterior glide, which means a posterior glide.
Right.
I'm not gonna have anybody in this room do the joint moves because we all learned how to. But for the practical, you will know how. You'll be tested on which joint moves and how to do it. Okay? But since we all learned it now, I don't have to have them show you again. So the posterior capsule is tight, so a posterior glide would come up limited, correct? What else? There also is a, thank you. Also, you'll have issues with the inferior because the inferior glenohumeral ligament is affected by this diagnosis. So you'll have limitation in inferior glide and limitation in posterior glide. Okay? Right?
Yes.
Good. Now, since their shirts off, you mentioned that scapular dyskinesia, right? What does scapular dyskinesia mean, Ryan?
Inferior angle is visible.
Ah, yes. So the inferior, it's classic scapular dyskinesia, the inferior angle is visible. What else, Ryan? What else for scapular dyskinesia? What would you see? So you see the inferior angle as,
There's winging.
there's scapular winging. What border is moving where it shouldn't?
The medial.
Yes, the medial side is popping up, right? The medial side should not be popping up on a healthy scapula. You see the medial side popped up, you see the inferior angle popped up. What else would you see?
Atrophy in the fingers.
But you already have a postural thing, right? Good.
Oh, yeah.
All right.
Yeah, first.
You would see atrophy where?
Infraspinatus.
Infraspinatus atrophy. Okay, I'll buy that. Now you further assess their posture, Sue-Win, and what do you see?
Forehead.
Their posture's crap, right? So come show everybody what crappy posture is. Forward head. Show us a forward head. Good. What else would we see?
Shoulder.
Show us rounded shoulders. Excellent. And what else? Scapular winging, which you can't see, but they would look like this. So poor posture.
You can't see that.
All right. So we got it. We know what's weak. We know what's tight, right? We assess their posture. We see what's bad. What special tests? Show us the special test you would do specific for this diagnosis. Joey will do it on the person of his choice.
Sulcus?
Show us the sulcus sign. How should the patient be sitting? Because this is what they'll be tested on, so show us properly.
Can you sit on the side of the plant?
I like, patient can be sitting or standing. I'm fine with sitting, yes. Yeah, I like to have the shoulder exposed so you can take a look. I don't know if this patient could expose her shoulder. Good. Good, very good, good. Yes, you have her bend the elbow to 90 degrees. Good. You hold on to the shaft of the humerus and you pull straight down. Can you see this?
Mm-hmm.
No. Don't pull enough where you pull her whole body. Pull just to observe the humeral head. If it has too much inferior movement, that's a positive sign.
Oh, yeah.
Like Liz. Liz has an excellent one, but I would not ask her to put it on film. That's up to her. What's another one? So sulcus sign is one. Excellent. What's another special test? You want to go? Take over. What's it called?
Bicep load.
Bicep load. Well, show us the bicep load. And what is the bicep load for? What? Testing what?
Biceps and then
Tendinitis.
No. Bicep load effects is for what? More specifically.
testing for the slap tear.
Slap tear. Why a slap tear?
Because where the bicep tendon inserts is right where.
Yes, so the type 2 slap tear, which is the most common in overhead athletes, right? Affects the bicep tendon. The bicep tendon attaches at the superior labrum. This, if there's a positive sign, that's a positive sign for slap. So the patient's in what position?
Supine.
Supine, 90 degrees of abduction.
I will ask to bend the elbow and I will resist.
You will resist elbow flexion in this position. Does everybody see that? A positive sign is what?
Pain.
Pain. In the exact area where the slap tear occurred. The long head of the bicep. That's the bicep load. What's another special test you would do?
Speed test.
How would we do the speed test, Ryan? Do it on somebody.
Have the patient extend the arm and other.
So what? How many degrees? Extend the elbow and flex the arms. How many degrees?
Flex to 90 degrees.
90 degrees. I like it.
And then try to make the patient flex more, and I'm going to resist it.
So resisted shoulder flexion. I like to have the other hand right in the bicipital groove. right? So here's the bicipital groove, 90 degrees. I'm gonna try to push your arm down, don't let me. If the pain is right where my finger is, that's a sign for bicep tendinitis, okay? You could have a positive sign of a slap issue of the positive bicipital tendinitis, then you would further test to make sure it's not just bicipital tendinitis, because the bicep load will be positive more so for a slap than bicipital tendinitis. Okay, good. What else? That's the special test you're doing? Excellent. Now, what if you're worried about a patient mentions they're on a bunch of heart medications and they're 100 pounds overweight and they love eating fried food, like the documentary that we saw, and you're worried maybe everything comes out negative, but the pain is somewhere around here, and you're worried it's a myocardial infarction or a heart attack. Tell me something about it.
The heart is innervated from the C4 to T4, so also the shoulders pain can refer to the shoulder.
On which side?
Left side.
Left side, very good. So if you have heart issues, it's innervated, say it again, I love that. C4 to T4, right? This area, you could have pain right here, and a patient can come in and say, I have shoulder pain, but if you take a proper history, medication, yeah, I stopped those dumb heart medications a long time ago. No real history of any overhead movement. They're coming with pain. It even hurts up in the side of the neck, shooting down the arm. That could be a sign of heart issues, not shoulder pain. So heart issues can affect mimic shoulder pain. Very good. Okay, any questions thus far in the assessment portion? We know what's weak, we know what's tight, we know how the capsule's affected. We have the special test to rule out other things and confirm our diagnosis. Any questions thus far? Good.
Bicep load and speed test can both test for bicep tendinitis?
No, bicep load will save you for slap, and speed test is for bicipital tendinitis. Okay, good. Now, strengthening. Sue-in. So we said what is weak? The sits muscles are weak, right? Whenever we have stages from stage 1 to stage 3, stage 1 is always the easiest. Stage 3 we assume is they're about to be discharged. Most aggressive in the 3rd stage or final stage, least aggressive in the 1st stage, right? Okay, so starting levels. How do we do shoulder internal and external rotation with, I might have said elbow at neutral, I meant elbow at the side. So show us a good exercise. We're using, let's pretend like, show us, how would you do internal and external rotation with the shoulder, with the elbow at the sides? And shoulder in neutral. So shoulder in neutral, elbow out the side.
Remember?
But let's do it against the wall, put a towel under the arm, let's do it properly. There's a towel, Alan's is a towel for you.
Using a TheraBand?
Use a TheraBand, there's a TheraBand, yeah, you use a TheraBand. Wrap it against something. And standing? No, you want to have good resistance. So you start at the stomach, and you come only till 90 degrees or 45 degrees, whatever. That's good. Now for internal rotation, no, you start it here, and you go then in. So you don't get too good. That's great, but if you're not worth, you're worth more than a pull, right? If it was my clinic, I would not waste humans on holding something. How could you show us? Wrap it around the door. That's a waste of talent, just to be holding the TheraBand. That should be my job, not yours. Excellent. You see, proper way to do internal and external rotation. Good. How about scapular retraction? We could do with the elbows bent. That's fine. Shoulders, good. But I'm a fan of doing both arms at the same time. Why waste it? Alan's is a bigger one for you. He knew what was happening. Good. The towel could remain between your legs or not. If you have incontinence, you can leave it there. What's the proper way to do it? So relax, good. Come forward, stop here, squeeze the shoulder blades. Okay, we're past just theoretical. Aren't you guys doing this in the clinic already? Yeah. So then do it right, damn it. Good. This is all on film. It's like, what am I doing? Good. Okay, excellent. Next, how would you strengthen the core? The first level, when you're strengthening the core, guys. Oh, by the way, how do we test for core strength? Here's another test. You read all the time, weak core, right? This is how I like testing for core. The patient is lying on the back. I'm part of their team, by the way. The patient's lying supine, leg flat on the floor. One leg comes up. The patient bridges higher. The patient holds that. If you see aggressive vertical or horizontal or vertical movement after 30 seconds, before 30 seconds of hold, that means they have weakness. If you really want to test the patient, do it again. Arms in the air. That makes it a little bit harder. There you see that. Now, in the research said you should have some kind of fancy dynamometer that has like, but we don't have that at LaGuardia. Just look. If the patient cannot hold that position, they're flying all over the place like it's a windy day. That's how I test for core. That's a good way to test core. So if they have weak core strength, that's the way to do it. Now that you're there, the first levels of core strengthening, where do you want the scapulas to be? On the mat. So how would you strengthen the core? With the scapula remaining on the mat. Can we have a therapist showing them?
Show me.
So we're gonna do, what is this exercise called?
Posterior pelvic tilt.
So in Michigan, do they call posterior posterior? They
When
do.
we say human.
All right, so I like to say because posterior pelvic tilt sounds like postural pelvic. Anyway, a posterior or posterior, depending on what part of the country you're from, pelvic tilt.
But your
posterior.
Whatever.
Who says a posterior?
Huh?
Who says posterior?
Posterior.
In Michigan, they call it posterior.
I don't know.
I'm not making fun of one of my favorite states. All right, so this is so you're doing a posterior pelvic tilt. Do it on this side so the camera can see. Come around this way. The patient has never done a posterior pelvic tilt. If you tell them do a posterior pelvic tilt, what does that mean? I don't know what that means. So how do we do it?
Remember?
Look at
Put
this,
your hand
genius.
under my back.
And then squeeze your.
Use your right hand.
So the patient, yes, the therapist is, get in there. Good. So the hand there is just to make sure that the posterior pelvic tilt is occurring. The therapist tells the patient to do what?
Squeeze your.
stomach.
And squeeze the stomach and what?
Press my.
Yes,
My
crush
hand.
the patient's hand. If you visualize it, if they're crushing the patient's hand, you're doing a posterior pelvic tilt. To do that, they have to fire their core, right?
Yes.
And they have to tell them to breathe. If their face turns beet red to win, they're not breathing. Good. Breathe. So that is a great core strengthening with their scapula on the table. Excellent. So that is phase one. You got it, the internal external rotation, the scapular retraction, the core stabilization. Now we're gonna progress. How would we progress the internal external rotation?
There.
Yes, show us internal, Ryan, show your patient internal and external rotation at the various degrees of shoulder abduction. On the patient. The patient doesn't know what the heck's going on.
All right.
Again, guys, you're thinking of these weird ways to use the TheraBand, and I appreciate that. But you keep it simple. Just tie it to the freaking wall. I'm not saying other ones are wrong, but start off nice and simple. I've taken rope courses myself. I get it. Okay, but start easy. Easy. There you go, Ryan. Especially in the heat of a practical, I've seen it where they're trying to do like slip knots and this, trying to get it over the ceiling. Okay. Take a step forward. Good. The patient could be seated as well. That's internal. What about external?
No, so the other side.
No, with this arm.
Okay.
In.
Under.
So,
That's internal. How do you do external?
so like this.
Put it under.
No, that's still
Under.
internal.
Under.
You gotta face it.
Oh, yeah.
Yeah, keep it simple. Do the same thing.
Starting internal.
Good.
Okay.
I love it. Again, you can do any fancy way you want, but isn't this easy?
Yeah.
I'm a fan of easy, especially the patient who's never done these exercises before. You're not going to say like, whatever you're going to say. Keep it simple. Good. That's a good. You see how this is much more difficult than the way at the arm. Good. Now, what about this scapular retraction? A more difficult version of retraction with a weight. Suwin killed it with 3 pounds. I didn't think she could do it. My bad.
Oh, that's for the TI.
Yes.
CY size.
Is that what?
Yeah, make sure there's room though. Make sure there's room. So this is getting all the muscles that attach the scapula.
Huh?
Yes, thank you, Sue.
Bring your arm up, pull your scapula back.
Yes, she don't have to go all up. She could just go up till
Right
here,
Nice.
and then I I actually move the scapula with her, so she knows exactly what I'm talking about. Come down. Good. Come up. Bring your scapula, the shoulder blade this way. Hold it 3 seconds. Good. These are T's. Y. It looks like a T. No. Now Y. Now Y's. Look at the Y's. And this way, this time the scapula is going this way. You see. So bring your scapula this way and hold it. Good. That's a good Y. And I.
I.
Bring
your arm up. Same way.
There you go. That's a good advancement of muscles specifically. And now in phase 2, which we didn't do in phase 1, we're working on what? The Pacquiao muscles. Right? And I've said this a million times, the serratus anterior, show us the serratus anterior strengthening. The serratus anterior is a forgotten muscle. And I'm on a crusade to make my pecs, my serratus anteriors look like a Pacquiao, which will never happen.
But you went
Yes.
vegan?
Huh?
But you went vegan. It's gonna come in like 3
I'm
days.
gonna get
Next month.
If you watch that video, my hair's gonna grow back. I'm gonna grow 6 feet.
Have you done keto yet?
No, keto is the opposite of the vegan. Show us the raised
I've never
punch.
seen- Huh?
Yes, the elbow remains straight. You're lifting the scapula off the table. That's a great, so you starting getting the serratus anterior. Good. Now, since you're there, we're doing core stability with scapulas engaged. Hollow hold. These are really hard, but hollow hold. So when I say scapulas engaged, I mean the scapulas are off the table. That's the next level. First, you start with scapulas on the table, nice and easy. Do it off the table. Good. A crunch is good. A full sit-up is good. Hollow hold is good. Excellent. All right. Now, level 3. This patient is what? She's a volleyball player.
Yeah.
Can we see some sports-specific movements?
Where's the thing go? Do we have you guys still here?
I'm looking.
And you want to take over? I gotta check something.
Wait, all right. So yeah, let me see it. Let me see it. So this is core. This is good too. Yes. So I like that. That is a sport specific movement, as you can see. The patient is strengthened for the spike. You see the spike? You can do concentric and eccentric. Good.
Trunk rotation.
Yes, which also works the core. I love it. How about this one? Patient stand here, and we're going to emulate a strike. So this is volleyball because we don't have the money. So I'm going to throw it in the air. You're going to go into the air and spike it to the ground.
I don't have to jump, do I?
Or you can't jump?
I can jump, but I look goofy.
It's only on film, all right? So I'm going to throw it up. You're going to spike it to the ground, all right?
Now that you
This is a great sports-specific exercise. We're emulating the sport in the clinic. Are you ready?
Tell me, spike that shit.
Excellent. I see your accuracy is improved. Excellent. So the point is that in the clinic, you're gonna have to think outside the box. The person plays tennis and you don't play tennis, then go look it up for the next time.
That's the first time I've ever spiked a volleyball.
Anyway,
Pretty good,
I'll
pretty
be
good,
fine,
pretty
I'll be fine. And the last one, closed kinetic chain upper extremity
That's later when
stability
he's born.
exercises. I like what they came up with. Show everybody. Who wants to show me a closed kinetic chain?
That's what you came up with.
Not me. I'm not that advanced, trust me. You guys thought of the, I like the, but now look what's going on. So now it's great upper extremity stability in the closed chain to do like a plank, but to move it around a little bit. It's difficult to do.
I'm not doing all the exercises.
I think Sue-In should do all that. Yes. All right, very good. All right, how about postural re-education? Look, Sue-In, I'm sitting like this. How can you, come here and fix me. You're missing one thing. So shoulder blades back, chin in. Well, at the end of the semester, we'll get into real postural assessment. But that's a good thing. Just tell the patient, sit up, squeeze your shoulder blades good, chin back. Perfect. All right, good. What about stretching? Are you guys stretching? Oh, did we talk about stretching? All right, let's talk about stretching. So, how could you stretch your posterior capsule? Ryan, how can you teach a patient to stretch their posterior capsule?
Using the BBC bike for internal rotation.
Okay. Show us that. Where? That's going to stretch the posterior capsule. I don't see I see anterior capsule being stretched. How would you stretch the post? Look at those guys. Look at those guys.
Do it, Kevin.
Look, cross body stretch. Definitely know how to do it. That definitely see how that stretches the posterior capsule. What else? This group came up with a good one. What was the one you guys had? Show us the sleeper stretch. Watch this one. Sometimes sleeping in class pays off.
It's like this.
Face the camera. So look, sleeper stretch. That stretches the posterior capsule. You see that? What about prayer stretch or child's pose? You don't do yoga in Jersey? That opens the posterior a little bit. How about foam roller to the left? Oh, show us that one.
That's a yoga thing.
Show us this one. I like this.
Wow, they like.
Yes. Can you get a foam roller, please?
Don't be one of those little ones.
I think we got that.
On the floor. On the floor. Foam roller to the lats.
Like that.
In this area.
Feels great.
We do the squat like that. That's it.
Save
Oh, that's
15%
Yes.
off. Liz.
Look,
15.
film that, film that, film that. Foam roller to the lats is a good one too.
Oh, I missed it.
Foam roller to the lats.
Who were you filming while I was doing it?
Do it again.
Liz was doing a stretch.
Oh.
Yes, foam roller to that area is a good way to stretch because if your lats are tight.
I'm tired, man.
Right, good. Finally, you said 2 glides. Which glides?
Inferior.
Inferior glide. So the early stages, what are you doing? What kind of glides are you doing? What levels of glides? Ones and twos, and then later on you're doing 3s and 4s for the inferior glide. The same thing for the posterior glide. 1s and 2s in the early stages, 3s and 4s in the later stages. Does anybody have any questions on that treatment? Excellent job treating your patient. You have a question, it's your case. What's your question?
In the slide, you said the weakness in the external rotation. But why is tight in the posterior?
It's tight in the posterior capsule because when the patient does constant overhead movement,
So why is weakness in the external rotation?
they're not sure because they think that perhaps this constant movement affects the nerve. And that's why there's weakness. They're not 100% sure. It's a good question. They think it's because constant motion affects the whole area. So they think it might be nerve related. That's why you see atrophy. They're not 100% sure. Good question. Okay, next one. It's now. All right, Joe, it's on you. What's your case?
JJ.
What's your case? Quick, what's your case?
18-year-old right-hand dominant. 2.
Okay, number 2. 18-year-old, come up. Joe, are you guys ready? 18-year-old right-hand dominant male comes to your clinic with an MD script for treat right shoulder subacromial impingement. He started to experience shoulder pain about 4 weeks ago and attributes the cause to playing tennis 3 times a week and not playing at all over the winter. His shoulder pain is 5 out of 10 when he reaches forward, reaches back, lifting of any type, and playing tennis. He also displays difficulty reaching behind his back to loop his belt or tuck his shirt in. X-rays were negative for bony abnormalities. Okay, so you think the diagnosis is what? Subacromial impingement. Very good. All right. Where is the pain for subacromial impingement?
Anterior shoulder.
Talk to the crew.
Anterior shoulder.
Yes, so subacromial impingement, classically the pain is in the anterior shoulder. Good. What activities cause pain?
Repetitive overhead movement.
Yes, so he plays tennis, repetitive overhead movement. Good. That makes the pain worse. What ADLs are classic with this diagnosis?
Can't tuck his shirt, can't reach behind his back to loop his belt, and if you're a woman, you can't dine and doff a bra.
Right, and what movement is that?
Internal rotation.
Internal rotation. Internal rotation, right? Internal rotation is the key. Watch out, they're all sitting out there. Go out this door. All right. All right, so when you do a postural eval or a scapular inspection, what do you find?
Winging. Oh.
Yeah, winging.
Winging of the scapula, which is on which border?
The medial border.
Medial border. What else?
Kyphotic T-spine.
Kyphotic posture, like Wynn was showing us, right? And what else?
Infra and supra atrophy.
You will see infraspinatus and supraspinatus atrophy. Again, they're not really 100% sure. Good. That was your visual inspection. They have poor posture. Their posture's crap. When you talk to them, they can't do ADLs like we discussed. repetitive overhead movement works, is painful. Very good. Now, active range of motion, you will find what when you do active range of motion testing?
Pain when you are going to flexion from 60 to 120 degrees.
What is that known as?
The arc of painful arc.
The arc of pain just sounds
Arc.
so fancy. Painful arc. So the classic painful arc is an abduction. You know what the painful arc is? No pain. Once you hit 60, there's pain until 120 degrees, and after 120 degrees, no pain. According to the research, you'll have a painful arc in abduction. You also could have a painful arc in flexion. Very good. What else?
So yeah, abduction 60 to 120, and then internal rotation, external rotation.
So external rotation and internal rotation, active range of motion deficit, right? Painful arcs in flexion and extension. Very good. What's next on your thing? Manual muscle testing?
Yeah, weakness.
Weakness in what?
All of the rotator.
All rotator cuff muscles are weak. What else is weak?
Serratus anterior.
The serratus anterior. That's the forgotten muscle.
It's an accessory movement for the scapula.
Why the serratus anterior specifically? Why the serratus anterior specifically? Why that?
It's involved with the upward rotation of the scapula.
Upward rotation. What else does the serratus anterior do?
Protraction.
Posterior tipping, protraction. All these movements help the scapula go through its motion without shoving it into the subacromial space. If the serratus anterior is weak, then the scapula is not moving properly, and the subacromial space will become impinged. Does that make sense? So you must. Can't tell you how many therapists forget about the serratus anterior. You will not forget the serratus anterior. So rotator cuff muscles, serratus anterior. What else? Mid traps, lower traps, and yeah, all right. Shoulder flexion is weak. Got it? That's what's weak. What's tight?
Pec major, pec minor, and posterior shoulder.
So the posterior shoulder tightness, pec major, and pec minor. Okay, you also have what? Since you said winging, what's that a fancy way to say that? Scapular dyskinesia. We'll get into that in a second. What special test do you do to rule in your diagnosis?
So the first one.
Josh will show it to us. What's the first one?
Empty can. So like this.
Empty can test.
Come here like it's caption. Like that.
Basically,
Yeah. So basically, here I'm just going to get shoulder flexion and go into it. If there's pain, it's a positive.
and what's the key? You're in scaption, and what else is going on?
Flexion.
Resisting flexion. What else is going on? Why empty can? Who cares what can's empty, full, or whatever? What thumb to the floor means what?
Internal rotation.
Internal rotation. Key. If you do not do internal rotation, you're not really invading the subacromial space. So you must have scaption, you must have internal rotation, you resist flexion with internal rotation. A positive sign is pain. That's Neer's impingement. What's the next special test? That was empty can, sorry.
Hawkins Kennedy.
No, near impingement.
Neer impingement is next.
So it's the same thing. You're going to scaption, internally rotate. Alright, I'm going to do it passively while you're pressing scapula. Go here. And it's the
Yes.
same positive.
So if the patient is much taller than you, it's better that the patient is sitting.
Right, okay.
Because you want to go from internal rotation, it must be internal rotation, into full extension, all in what? Passive or active?
Passive.
All passive. A positive sign is?
So extension is the flexion.
I'm in flexion, into full flexion. Got it?
Right.
With internal rotation, a positive sign is
Pain.
pain because you are, again, invading the subacromial space. What's the next one?
Hawkins Kennedy.
Hawkins Kennedy.
You can actually sit down.
Thank you. Now you're using your noggin to make sure that we can see this on video.
Sit down. So you're going to go like this. You can internally rotate. And then you can come this side, I guess. And I'm just going to force him to internally rotate.
Yes, so make sure full internal rotation. The thumb is, turn the thumb all the way down. There you go. So that is the European version of the Hawkins Kennedy. Again, you're forcing internal rotation. The other way to do it is without, see how Josh's arm comes across? The other one is, yeah, this like this.
Oh, just going like this.
Like this way. But I like having the arm across. It makes you look like professional.
Sure.
But yes, you're doing passive internal rotation at 90 degrees of abduction. A positive sign is what?
Pain.
Good. You mentioned scapular issues. So what are two specific scapular tests?
So the first one is scapular repositioning. So you can just sit down again. Yeah.
So the patient's shirt is off. What's the point otherwise? But we're not gonna do that to you or us.
I thought that was just the
Which one are you repositioning? It's still good to have it off. So you
Oh.
can,
In front of everybody.
So you're just going to do shoulder flexion, right? Go ahead. and then if you can't get beyond a certain point, I'm gonna posteriorly tip your scapula, and if you can go beyond 90 degrees, or if you can go to the full range of motion, then the issues come from the scapula.
So the patient has pain, or the painful arc, for example, right? But then what does the serratus anterior do as far as tilting of the scapula? It does what? Posterior tipping. If Josh posterior tips for the patient, and you can go into full flexion without any pain now, that tells you the subacromial space is being impinged, and the serratus anterior is probably the cause of it. That's a great special test. That's why you use the books. Good job.
Nice.
What's another one?
Scapular dyskinesia. So
Scapular dyskinesia is what?
Shirt wear off, and then he just takes like 2 dumbbells and he does shoulder flexion. Like
With how much weight?
Heavy weights.
It should be a weight that's heavy.
Yeah.
Yes, you do. No,
Like this.
something like this.
Yeah.
And you compare both shoulder blades.
Yes.
Keep on going. Sorry to cut
And
you
a
off.
positive sign is just winging with the scapula.
The scapula goes crazy after 3 to 5 reps because you're having these muscles that are weak work and they can't handle it. And you'll see winging immediately after the 3rd or 5th rep. Got it? Those are the special tests. Good. What about a red flag and NSAIDs?
So a red flag would be if you have pain after eating, and it would be a red flag if you had a prior medical history of having ulcers and you're currently taking NSAIDs. So some of the symptoms are nausea, loss of appetite, and having blood in your stool, and it can refer pain up to your right shoulder.
Right. So NSAIDs like Advil is a COX-1 inhibitor. What's a COX-1 inhibitor? It basically stops inflammation, but all over. Advil doesn't care where the inflammation stops. It stops inflammation. You need inflammation in your digestive tract to protect the esophagus, for example. If you overdo the NSAIDs, it could actually put a hole in your esophagus. In this blood in the stool, yes, because now this blood is going somewhere. It goes to your GI tract. But also you could cough up blood, vomit blood, and pain in the shoulder is one of them. So the patient goes, yeah, I take those Advil. I take about 6 in the morning, 12 in the afternoon, and 14 at night. Then that's something like, well, that's a problem. Okay, good. Now, plan of care. We have a couple of phases. So you mentioned that so things that we already showed, we don't have to show again.
Okay.
So in phase 1, you want to take it easy. You do not want to go into any position that impinges the subacromial space, right? So we're going to strengthen the rotator cuff muscles. Just show them. They're like the one with your arm at the side, right? That's nice and easy, right? You're not doing anything like this at first. That's crazy. Nice and easy. Okay. What else do you want to? What else as we said was weak? So internal and external rotation. You're going to do at that position at the side. What else are we strengthening? Abductors, but in this case we don't want to have internal rotation. So you want to make sure your thumb is up. Thumb up, you see what I'm saying? You don't have thumb down, though people that I work with do thumb down, it causes pain. Thumb up, use your brain. Thumb up is, exactly. What else? How about, what else is weak? You said are you forgetting the forgotten muscle?
No, that's
Don't
not.
forget the forgotten muscle.
So yeah, open chain serratus strengthening.
Open chain serratus strengthening, which you could do with lying down with the weight that Joey did, or you could do it with the TheraBand. Dennis, I know this is your favorite. Darren is your favorite, but they're doing it. Good. That's open chain. At least I get it right the next second. I'm not like calling you Frank and moving on. All right, open chain.
Open chain traps.
Wait. We had those. What kind of glides are you doing?
Posterior.
Posterior and inferior glides. Again, 1s and 2s early on. And then posterior. And then what else are you going to do? Posture re-education? Posterior re-education. Yeah, postural re-education. This is really postural, not postural.
So we're going to stretch the tight musculature now? Is that what you mean?
Yeah, how would you stretch the tight musculature?
Yeah, so we got against the door frame.
Show everybody. Follow him.
Impact minor above the nipple line. Impact major right here.
Yeah, or you could use this as well too.
Or you can use the foam roller.
Oh, lying down on the foam roller.
Yeah.
But I would use one a bit bigger.
Right, yeah.
I mean, they'll come for neck pain afterward.
Yeah, no.
Yeah.
Long one.
Long one, okay. I like it, good job.
Ooh, got
So
some
that's phase one, okay? So you're gonna have them fix their posture, stretch, strengthen the rotator cuff muscles in a non-aggressive position, serratus anterior, open chain. Phase two,
Yeah.
now we're adding what? There's one other thing that you said that was weak or painful. Now we could start adding because the patient's getting better.
Shoulder flexion.
Shoulder flexion, using a TheraBand. We could start doing shoulder flexion exercises.
Concentric and eccentric.
Yes.
Basically just
Nice and
slowly
easy,
rolling
very
back
good.
Down.
Good. Then, good, how about serratus anterior? Now it's going to close chain.
Protracting.
Protract, you can do it against the wall first, if that's too much, but on the floor is just as good. And now your glides, both posterior and inferior, are going to be grade 3s and 4s, and the stretches can be more aggressive.
Yes. So basically just the same stretch that I did against the door frame, but you can just go even deeper into it.
I like it.
And then the second one was just a sleeper stretch that I already done.
Sleeper stretch is really good for the posterior capsule.
Yep.
Finally, phase 3, now you're gonna strengthen everything. Again, don't go crazy. Just the ones that Ryan did, this one. Internal and external, now with various degrees of shoulder abduction. That's the most aggressive because arguably you are going into subacromial space. But now that you strengthen the serratus anterior, now that the patient's posture is better, you can now strengthen at various levels, right? Does this patient have any specific functional deficits? How could you give him an exercise? Joe, your bra, it's very hard for you to put on.
Oh, yeah.
What exercise could you do to improve that?
Bra.
Bra. How do you say it? Bra?
Bra? Bra?
Bra?
Right?
Wait, how do you say the thing where you put your clothes in?
What do you mean?
That thing.
Closet?
No.
Drawer?
Drawer.
Drawer?
Drawer. Who says drawer?
I do. Drawer.
No one says drawer.
Yeah.
Drawer.
What do they say in Maryland?
How do you say car?
You don't say drawer.
I just did.
Drawer. Drawer.
Nobody.
Open the drawers. No.
Yeah, that sounds good.
All right. Anyway, we're not testing you on that. All right. Anyway, good. We have the 3 phases. I like. Well, show us a specific functional exercise. Good. Now we could go get his bra. Drawers.
Brawl.
The bro.
The guys are brawling outside.
I don't know what this is about. You're strengthening your right
Now,
triceps.
oh, you were saying
If you're gonna do a stretch, then you.
Right, sorry, yeah.
You should be doing it with the TheraBand.
Thank you, Alan. Thank you.
Stretching.
Use the thing.
Towel, yeah, which would make a lot more sense.
All right, good. That's a good. Like on the practical, you all got
Turn
these,
to
like
me.
these pop questions, right? That everyone did fine on. Be ready for questions like this.
There you go.
That you don't. There you go. I like it. Okay. Any questions on this progression? Very good. All right. Next group. 40. Good job. 47-year-old right-hand dominant male man is referred to your clinic with a diagnosis of right shoulder pain. He slipped on the ice and reported that his shoulder popped out and it went back in again. And I'm going to say he fell like this on the ice. All right? He fell like this on the ice, the son of a gun. He attempted to go back to work today, but he had to leave because of 7 out of 10 pain and a sense that his shoulder would come out again if he tried to lift mail bags from the floor. X-rays taken by the MD showed no obvious bony abnormalities and no additional images was performed. All right, so the patient presentation. Where would they have pain? You guys think it's what, based on this whole story?
Anterior dislocation.
An anterior dislocation, which is the most common. Very good. So where would they have tenderness?
Delta pectoral.
Where? Show us on the skeleton. Where's the deltopectoral groove? Yes, where the deltoids and the pecs meet, right around there, because that's exactly where it pops out, right at the anterior deltopec groove. Good. They will also have pain where else? I'll buy that in the bicipital groove for sure. Okay. I'm going to tell you right now, all that extra imaging that I have in the lecture, know everything in the lecture, like the Bankart lesion, all those lesions, definitely know about that. Okay. So what range of motion deficits will they have? Before you tell me specifics, what do you think? Yes, the range of motion that popped that sucker out to begin with. That will not be good for the patient. The patient wants nothing to do with it. So, specifically, what will they have decreased? Active what range of motions? Joanna?
External rotation and abduction.
Yes. And I'm even gonna say flexion also, like you guys mentioned, I'll buy that. But for sure, this motion. When they start going into this motion, they're not happy. Kevin, manual muscle testing will reveal weakness in what?
External rotators.
Just the shoulder rotators, all right. He doesn't need it. You got it.
I don't need that.
You don't need that, all right? Now, Darren, are you ready to show us the special tests on Kevin since he's right here? All right, what are the two special tests? So I'm gonna say the sulcus sign everyone saw already, right? The sulcus sign is one of the special tests, bless you, but we're not gonna repeat it because everyone saw it. Okay, that's one of the special tests. What's the other special test?
Apprehension test.
How do we do the apprehension test? Do it.
So you do
The patient is lying in what position?
in supine.
Patient's lying in supine.
Right. And then you do a 90-90.
Show us.
So 90-90, and then you try to push it down.
And what is a positive sign?
The patient will be in pain.
Well, the patient will say, "What the heck are you doing?"
Right.
In other words, you're recreating this position, right? So what you do, yes, but if it's real, it'd be really easy. So you start here and you're slowly going this way. I've seen cases where the patient always like, "Stop," like you're recreating that. They say stop. They have this look of fear on their face. They're in extreme pain. That's a positive sign. Very good. Now, Kevin. What about urological issues and shoulder pain?
Preferred pain from hip to the shoulder.
Right, so if the person has urological issues, what organ is most likely affected? Bladder or kidneys, specifically kidney. You could have kidney pain and it can refer to the shoulder. So speaking to the patient, reading their history is a very good thing to do before. So you got all that? Good. Okay, Liz. So now that now in the case where you feel it is a shoulder dislocation, what do you tell the patient to do? Hardcore exercises?
No.
What do you tell them to do?
Sling. Above leg.
All right, you don't tell them that.
Well,
where do you send them?
To get imaging.
Yes, you send them to the ER, their doctor immediately. You're not taking care of this patient. If you suspect a dislocation, you say, "I think you had a dislocation. You need to go to the doctor right now." They go to the doctor thanks you, gives you a gold watch, and you saved this patient. Thank you. What does the doctor then tell them to do first?
Sling for 6 weeks.
Sling for 6 weeks. What position is the arm in?
Externally rotated.
You're lucky. I used to have a sling here, and I used to you have to be able to put it on for the practical, but the guy whose sling it was took it back. So the research says external rotation is better than internal rotation. Good. All right, Joanna. So while they're in the sling, what do? Nothing?
We can exercise, we can use isometrics, for example, for elbow flexion and extension. We can exercise the fingers, for example, squeeze balls or
Yes.
or
What
something
else?
like that. And wrist.
Wrist. Very
Radial
good.
and ulnar deviation we can use.
Excellent.
Weights.
You're going to strengthen the joints that are not affected. You're not just going to let the person stay in a sling. Very good. You got all that? Isometric elbow flexion extension. I like it. Active resistive wrist extension flexion. You could do all that while in the sling. Gripping. A lot of slings come with squeezy balls. Right? You can squeeze those. Very good. All right. And now stage 2, Darren. So in stage 2, we want to start strengthening the area, right? But we don't want to do this aggressive movement just yet. The patient is not ready. So what do we want to do?
You can do a quadruped, like a push-up.
All right, so you want to strengthen the posterior muscles, but in a position that's not dangerous for the patient. So show us. So now, this is a smart group, what they came up with. You're going to strengthen
like
the
this.
scapular muscles.
And then just go up, go down, like backward, forward.
All right, that's as safe as you could do it in low plank or high plank. But you see, show us again in the high plank so they can see. Scapular depression, elevation and depression, like that, nice and slow, protraction and retraction, with no movement. It could be all at the top. That strengthens those muscles without hurting the shoulder. I love it. What's another good one you could do? So we're not going to strengthen external rotators. That's crazy. But what can we do? Show us an isometric for internal rotation.
Darren came up with this himself.
Or you do it like this.
You did.
Do a
yeah.
squeeze.
Squeeze it. Have a seat. Squeeze the pillow. I love it. So you're strengthening the posterior structures in a safe manner, internal rotation rather, and the posterior structures in a safe manner. I love it. That's stage one. Stage two.
Quick question.
That was stage two. Thank you, Liz. Yes.
That will be isometric internal rotation.
Internal rotation.
But they're going to be in a sling and external rotation.
No, they're not sling like this. They're sling like this.
Oh.
Slight external rotation, not all the way here.
I was confused for a second.
Yeah. But when they're doing these exercises, they could take the sling off and do, you know, if it's okay, they could do that in stage two. We're past the sling. We're past the sling. Now they might still be in the sling a little bit, but if they're ready for stage two, they're ready to do these exercises outside of the sling. Okay, now you're doing great, therapist. They're getting better. The range of motion is normalized. There's no longer a fear that it's going to pop out at any minute. Now we're ready for the stage three. Darren, I'm going to say this to you because you love this exercise, but we did it a million times already. We're going to strengthen what's one muscle we're going to stretch?
Serratus anterior.
All right, so an easy serratus anterior exercise is what?
You can do theraband punches.
Yes, we're going to call this the Darren. Yes, yes, that's one. And then that progresses to what? Show us against the wall.
Like wall push-ups.
Wall push-ups, good. Yes, and then you can progress to the floor. Very good. What about the mid-lower traps?
T's, but not T's.
Yeah, so show us the easier, the phase one of the T's and then the actual T's with the weight. So you want to start doing horizontal abduction, but not in a position at 90 degrees, below 90 degrees. Show us, Liz.
Hi.
Move your stuff.
She just kicked it out.
Yeah, nice and easy, nice and easy. And then as the phase two will be a real T when you're at 90 degrees, okay? Good, very good. And then the infraspinatus and teres minor, we're gonna start on what's a nice, safe position to strengthen shoulder external rotators, but not aggressive. Show us, Kevin, the sideline version. Throw him a weight. Do it again, get the camera moved so we're good. So the patient is side lying, good. The involved side, why am I doing this? The involved side, take that behind Joey, put that under his armpit. The involved side is up. The patient, no one can see you but me, which is how it should be. Go behind him and make sure he's doing it right. So the patient starts in the gut. Patient starts in the gut and only comes up as high as that much. Yes, and then comes down slowly. Nice and slow each direction. That's a nice, safe way to do it. And then the more aggressive is what Ryan did, like this. Because this is the motion that created the problem, but the patient now is ready to do this. So the TheraBand's in front of him, he's coming back slowly into this position. Concentric and eccentric. External rotation, but in this position. Very good. How would we do, Joanna, internal rotation, side lying at first?
Inside line?
Yes, so the affected side is where? On top or down, on the bottom?
It can be both. It can be.
No, we're doing internal rotation.
Oh, okay. So on top.
No, on the bottom. The affected side is now, he's lying on his affected side. He's starting this way and going in like this. Move that way. If you're gonna put it under the armpit, put it under the armpit. That thing, there you go. And now that's a good phase one, slowly. There you go, that's good phase one. Going from there into the gut, good. And phase two would be the one that Ryan was doing. Internal rotation at this position. Got it? Good. And then finally, closed chain in an unstable surface. Do we have a Bosu ball? So turn the Bosu ball upside down and have, do what Darren was doing, protraction and retraction on the Bosu ball in a push-up position. We got that? Very good. Any questions? Good job. How many groups do we have left? One? Yes. No, I'm saying yes because I love learning. All right, finally, a 36-year-old right-hand dominant. Very good. Let's give it a... You guys are thinking outside the box. I like it. I like it. A 36-year-old right head dominant male female referred to your clinic with a 2-month history of right shoulder pain. She first experienced this pain when fastening her bra. She denies any trauma to this area, and this is the first time she sought care for shoulder pain injury. The pain has increased since the onset now, so it was originally 2 out of 10, now it's 5 out of 10, and it affects her ability to sleep on her affected side. In addition, she has issue cleaning her house and reaching overhead and reaching behind her back. Do you like the pause?
Dun,
It makes
dun,
it more,
dun.
yeah. Good. All right, so as I forgot to erase, women get this more than men, 40 to 60 years of age. Okay, good. There are 2 types of wait, what's the diagnosis, Melissa?
Frozen shoulder.
Frozen shoulder, I love it. There's 2 types of frozen shoulder, or the cause of it. What are the 2 types?
Primary.
All right, and
Secondary.
what's the difference?
Primary is idiopathic, so there's no history or trauma or surgery.
Ah, exactly.
And secondary, it's a specific history like COPD or diabetes.
Yeah, or there was an injury, some kind of trauma,
Yeah.
all right, specific trauma. Good. Alan's, what's the actual cause, do they think?
Cytokines,
What are cytokines? They sound like some sci-fi thing.
proteins that kind of accumulate after this in some type of acute inflammation, injury.
Some autoimmune thing. These cytokines hang out and freeze the shoulder. I love it. Dennis, are you back there?
I'm here.
Can you give us a brief, and the key points to the 4 stages of this diagnosis? It used to be 3 stages, but the APTA added a 4th, so thank them. What are the 4 stages?
Pre-freezing.
Stage 1, okay, and
one time period?
yes, time period.
Time period is generally 1 to 3 months.
All right, and the patient describes pain when?
In activity, so this is when she's reaching overhead or
All right.
behind her.
So they could feel it at rest, but it really gets bad with activity. And range of motion deficit?
No.
There's not. They might be guarding and worried about pain, but they have full range of motion in this phase. Stage 2?
Stage 2 is denoted by freezing.
All right, what time period?
3 to 9 months.
Okay, the pain describes, when do they describe the pain?
Generally seen at night.
Especially at night, yes. Do they have range of motion deficits?
They have gradual decrease of range of motion.
Good. Stage 3?
Stage 3 is frozen.
Yes.
Time period is 9 to 14 months.
All right, and they describe pain when?
This is pain also at night.
Yes.
And at the end range.
Yes. Stage 4?
Stage 4 is thawing, and that's 12 to 15 months.
Yes.
And the patient describes pain in all activities, but it's diminished. That's its so
And
it's
the
on its
range
way
of
out.
motion deficits is only when?
End range
And
and
end range.
ADLs.
So it's already getting better. Very good. Okay.
Just want to make sure. I think you said decrease for 2. I think you meant increase. Gradual increase.
Don't worry, Alan does that to me all the time as well. It's not just me. It's not just me.
I just want to check for the video.
Wait, what?
It's decrease.
Decrease. I said decrease.
Decrease.
Oh, I'm gonna stop then.
Oh, go figure.
All right.
Anywho.
Anyway, all right. Assessment. The manual muscle testing will reveal weakness in what, Melissa?
All the delts.
All the delts. Disuse atrophy in the delts because it hurts to move. They don't move. They have disuse atrophy, okay? Good. What about the range of motion deficit, Alan's?
Sorry.
The range of motion deficits.
It's gonna be flexion, internal rotation, and.
Is it a capsular pattern?
Yes.
And if so, what is the capsular pattern?
It's going to be external rotation first, abduction, and then internal rotation.
Correct. Even though we discussed there's a lot of research that it doesn't follow a capsular pattern, we're going to say in general it does follow a capsular pattern, especially for the board exam, which I don't teach to. Okay. Dennis, will you do the special test on me?
Yes. All right. So is pain more than 3?
Oh, you can stop pushing now. Yes. Yes, so where are you pushing? Where are you pushing?
So just medial and inferior to the AC joint, which is the coracoid.
Yes. The coracoid process. Yes. You push on the coracoid process. You got it. Perfect. You push on the coracoid process. The pain is worse than 3 out of 10 because that hurt. That's a positive sign. Good. Plan of care. Phase 1,
Hey,
plan
what
of
about red
care.
flags?
Oh, red flags. What are the red flags for you guys?
Aortic aneurysm.
Yes, what about it?
So aortic aneurysm presents with chest pain.
What page do you get that from?
From page 190 in the red flags book.
Yeah.
Does it have it?
No, I don't have it. I know. Yeah. Go. The old version.
So it presents with chest pain that might extend to the neck.
What is aortic aneurysm?
Bursting of the.
Yes, the aorta. It's a problem. Okay, so they have pain that could go into the shoulder.
Yeah, but rarely to the joints.
Rarely to the joint. Okay.
Pain to the shoulder isn't enough to suggest aneurysm. The pain usually radiates the traps in upper arms.
Okay, good to know. Excellent. All right.
Radiating pain, and this is affecting her joints, which an aortic aneurysm rarely affects.
Okay, good. All right, now, what does the research say about treatment for this diagnosis? What's the word I want to hear? What's the word I want to hear?
Strangling?
Strangling?
Aggressive.
Aggressive, right.
The research says you must be aggressive with this diagnosis. Stretching's aggressive. Joint mobs are aggressive. If you're not aggressive, you have to break this frozen shoulder and get into a new range. Okay? The patient might not like you at first, but they will like you at the end of it. All right. The strengthening, yes, it's important. But the most important thing, I think, is getting that range of motion back. But if you were to strengthen, what will you strengthen?
All the delts.
The delts. Show us with a weight how to strengthen all the delts. I don't like going above 90 degrees. You can strengthen the delts just fine doing 90 degrees. Abduction. There you go. Good. You can do the same thing with a TheraBand, right?
Yep.
Good. All right. Now, what joint mobs are you doing for Arabir, for the capsular pattern?
Posterior for flexion.
Posterior.
Protection. And internal rotation.
Internal rotation is what? Posterior, good. What else?
You're doing inferior for abduction.
Inferior.
And anterior for
anterior.
extension.
And you're doing grades 1s and 2s, right?
Nope.
No. Thank you. No 1s and 2s. You heard me, Kevin?
Yes. No 1s and 2s.
No 1s and 2s. 3s and 4s. Hardcore. Hardcore. All right. Stretching on the patient. Show us how to stretch the patient's external rotation. Aggressive. Somebody get on the table. Pick the patient. How would you stretch aggressively the patient's external rotation? Into external rotation. So you're stretching their internal rotations to improve external rotation.
So you're going to go into internal rotation.
Internal rotation, all right. That's good. That's a fourth.
Distract me first.
No, this is just a stretch. Stretch.
I'm thinking too far ahead.
Good. That's internal rotation. How would you stretch the patient's into external rotation? Good. And how about abduction? Stretch to improve abduction. No, you want to improve abduction.
A bit more over here.
Get in there, man. Get in there. If it frozen, he won't be able to get that, but you get it, you're stretching, right? Mm-hmm. Right, so you want to do all the stretches. You're going to teach the patient how to self-stretch. Mm-hmm. How would they self-stretch to improve abduction?
I'd have them sitting. Is there a chair here?
This way.
So I'm going to stretch their adductors to improve abduction.
All right. You also could do this guy. Right? Good. How about flexion? Show us the PVC, that's fine. Or the table, whatever.
Take it from here.
That's good. You also could do this one for flexion. Internal rotation. Self-stretch.
Towel.
Show us on the towel. Good. And how about external rotation? To improve external rotation. PVC, I like it. Nice, you see that? PVC. What else if the patient has no PVC? How do they improve their external rotation?
Go towards the door.
Follow Alan's towards the door.
So let's say it's my right arm.
Look what he's doing.
Let's say it's my right arm. Face this way, then I turn away.
Yeah, so to do it, you have the patient like stand here, and you say, walk away from this arm, but the arm stays where it is. Like that, like you did, right? That's a great way. You're saying about the stretch in the doorway, but you're not really improving external rotation. It's staying the same. You're stretching your pecs, but your external rotation is not changing. So I like that one. You got all those?
Mm-hmm.
Good. That's good self-stretch. You do aggressive stretching on them. You do joint moves on them. And now a functional exercise. What do they do for a living? Well, guess what? Think about functional exercise.
Combing their hair.
Yeah, show us the combing the hair with the weight. Excellent. All right, so you got it? Any questions on these? No. So we have the video. You have to fill it. The whole sheet has to be filled out, and you have to go through this entire thing with 3 separate people. That will prepare you for the practical and the ring. We will see you at 3 o'clock.